Hey y'all, and welcome to my lecture on the disorders of puberty. Puberty is complicated, and we're getting rather in-depth today, so naturally I went with a Dante's Inferno theme for this lecture. Merry Christmas. These are the 9 circles that we will be descending today, the first of which is embryology. It is complicated, but it's also remarkable and very important for our pubertal development later in life. So taking it all the way back to the beginning, it is going to be the sperm that contains the sex-determining genetic potential for the new human, but this is not going to affect morphology until roughly week 7 of gestation. Prior to that, there are a few important steps that have to happen rather perfectly in succession for proper sexual development. The first of which is the migration of the primordial germ cells to invade the gonadal ridge here. And once that happens, we're known as the indifferent gonad. Again, until roughly week 7, when, if the Y chromosome is present, then the sex-determining region of Y will result in testes-determining factor being transcribed, which will ultimately result in the independent gonad forming the testes, Leydig, and Sertoli cells. This is going to mean that we have testosterone, and a male embryo will begin to form. Ultimately, the testosterone is converted to DHT, and this will result in the testes descending, God willing, into the scrotum at roughly month 7 of gestation. Additionally, Müllerian inhibitory factor is going to be present. This results in the degradation of the Müllerian duct, which in the female organism would of course become the uterus, cervix, and upper 2/3 of the vagina. Speaking of, in the absence of the Y chromosome, then around week 9 of gestation, the primitive sex cords get a little disorganized, and they become these clusters of germ cells, which are eventually going to become ovarian medulla. Surface epithelium is going to continue to proliferate and eventually become cortical cords. Around month 4 of gestation, they break off, cover these clusters of primitive germ cells, which are going to become oogonia. Surface epithelium will eventually turn into ovarian follicular cells. Interestingly, at its peak, the female fetus is going to have roughly 7 million oogonia, but by birth, this has already decreased to 2 million. And they are, of course, arrested in prophase of meiosis 1. Meanwhile, it's the urogenital ducts that are responsible for forming our sex organs. Wolffian ducts are the primary force in male sexual differentiation, where testosterone from Leydig cells as well as Müllerian inhibitory factor from the Sertoli cells are going to act synchronously along with DHT to result in the formation of the penis from the genital tubercle and the scrotum from the labioscrotal folds. In females, we've already mentioned, it's the Müllerian duct that ultimately becomes the uterus, cervix, and upper 2/3 of the vagina in the absence of the Y chromosome. Phew! That completes our whirlwind tour of the sexual differentiation of the human embryo. This was just to show you guys that it is very complicated and a lot of things have to happen perfectly for us to develop normal sexual differentiation. Now, if that all happens perfectly, then we can move on to normal puberty. So what exactly is puberty? It is defined as a process of reproductive maturity and fertility characterized by the development of our secondary sexual characteristics, a pubertal growth spurt, as well as psychological and cognitive changes. However, the technical medical definition of a patient who has entered puberty in girls is the appearance of thelarchy or breast bud development. This happens on average between 10 and 10.5 years, and roughly 2.5 years after that is when you can expect menarche. In boys, it is defined by a testicular volume of greater than 4 milliliters or 2.5 centimeters, and on average this is going to happen between 11 and 11.5 years. It is a reawakening of the hypothalamic pituitary gonadal axis that results in gonadorchy or early puberty. A GnRH pulse in the hypothalamus tells the anterior pituitary gland to release FSH and LH, which then go to the gonads, resulting in the production and release of estradiol in females and testosterone in boys. As you can see here, the hypothalamic pituitary gonadal axis is very active in utero and postnatally for a brief time, then goes into a period of somnolence before it is reawakened in puberty. So what is it that results in this reawakening? We don't exactly know, but we have identified a neuropeptide in the arcuate nucleus known as kisspeptin, which we think may play an important role. It was discovered in Hershey, Pennsylvania, which is why it's called kisspeptin. The normal sequence of puberty in females is thelarchy or breast development. This is going to require estrogen, followed by pubarchy or the development of pubic and axillary hair growth. This is going to require androgens, DHEA, most commonly produced by the adrenal glands. After that, the patient will reach peak height velocity, and then finally menarche, which is going to require GnRH from the hypothalamus, of course, FSH and LH from the pituitary, estrogen and progesterone from the ovaries, and a normal outflow tract. I have included here a picture for completeness of the hypothalamic pituitary ovarian axis, but what is important to take away from this is that it is FSH that results in the growth of ovarian follicles. LH is going to result in the production of estradiol, and this in conjunction with progesterone results in ovulation and menses. Estradiol is very important for breast development, skeleton growth, and ultimately the fusion of the growth plates. The normal sequence of puberty in males is first defined by testicular enlargement. This is usually accompanied by spermarchy or the first sperm production, which is going to require FSH and LH because we will be needing testosterone. This is followed by pubarchy or the development of pubic and axillary hair, acne, and apocrine body odor, primarily mediated by DHEA from the adrenal glands. After this, the patient will typically reach peak height velocity and conclude puberty with voice change. Again, for completeness, I have included a picture of the hypothalamic pituitary testicular axis. But what's important to take away is that FSH primarily acts in the Sertoli cells, resulting in the growth of the seminiferous tubules and increased testicular volume, whereas LH goes to the Leydig cells, resulting in the production or release of testosterone, which will give us penile growth, a deepening voice, hair growth, and ultimately be converted peripherally by aromatase into estrogen, which will result in skeletal maturation and closure of the growth plates. These are the expected perils of puberty or pathologies we will commonly encounter in our pubertal adolescents as family physicians. Myopia, you're going to see one of the greatest incidences here at puberty due to the rapid increase in axial diameter of the eye. Additionally, with scoliosis due to rapid axial skeleton growth, and anemia, gynecomastia, sports-related injury, and dysfunctional uterine bleeding are all common, as well as STIs and unwanted pregnancy. That's why it is vital, with parental consent, to speak to these patients one-on-one so that you can take a good sexual history and offer screening and contraception. Now on to our third circle, or precocious puberty. Precocious puberty is defined by pubertal onset before the age of 8 in girls, 7 if African American, or the age of 9 in boys. There are 3 categories by which we define precocious puberty, the first of which is central precocious puberty, or gonadotropin dependent, and this is the early activation of the hypothalamic pituitary gonadal axis, typically from brain pathologies. The second is peripheral precocity. This is gonadotropin independent, and this will be from things like congenital adrenal hyperplasia or Leydig cell tumors. And the third of which is benign variants. In defining precocious puberty, we do run into some gray areas. Typically, we define this as 2 to 2.5 standard deviations below the normal, but the normal can be hard to define with an at-large population reaching puberty earlier. One study showed that breast and pubic hair development was present at age 8 years in 48% of black females and 15% of white females. We know that there is a significant variation between race, adiposity, and family history can vary significantly. It is vital to do a good history and physical exam in these patients before you decide to pursue further workup. Our first category of precocious puberty is central precocious puberty, or gonadotropin dependent. These patients are going to have early activation of the hypothalamic pituitary gonadal axis and thus undergo true puberty just earlier. They're going to have the normal sequence and reach pubertal levels of LH and FSH. The most common cause of this is idiopathic, but you do want to be mindful of other causes like hypothalamic hamartomas, which are associated with galactic seizures, where patients will have uncontrolled laughing or crying, or a history of cranial irradiation. Bonus points if you know what this picture is from. Our second category of precocious puberty is peripheral or gonadotropin independent precocious puberty. These patients aren't truly undergoing central puberty, so the sequence is often abnormal and you'll have prepubertal levels of LH and FSH. Underlying causes include excess secretion of sex hormones from the gonads, such as in Leydig cell tumors in males, or functioning follicular cysts in females, or the adrenal glands, such as in CAH. But you can also have things like exogenous steroid exposure, or severe hypothyroidism that can result in peripheral precocity. A rare cause of peripheral precocious puberty is the McCune-Albright syndrome. This does have a female predominance and is a triad of fibrous dysplasia of bone, cafe au lait spots, and precocious puberty from functioning follicular cysts of the ovaries producing estrogen. The cafe au lait spots are typically described as having a coast of Maine appearance. Another cause of peripheral precocity is congenital adrenal hyperplasia, 95% of which is 21-hydroxylase deficiency. Typically, we think of CAH as presenting in the neonatal period with salt wasting, virilization, and hypokalemia. However, there is a significant variability in how this can present in patients, especially heterozygotes, in which it is called non-classic CAH and can present with peripheral precocious puberty. Our third category of precocious puberty are the benign variants. So these are things like early adrenarche, lipomastia, vaginal bleeding in infancy, again resulting from this GnRH pulsation early in life, and then familial forms. These all can be observed every 3 to 6 months. And then on to our fourth circle, delayed puberty. So delayed puberty is defined as no signs of breast development by 13 years in girls and no menarche by age 14, and in boys, no testicular enlargement by age 14. There are many causes of delayed puberty, but we do divide these into primary and secondary forms and then further subcategorize if they are congenital or acquired. We will not cover everything, but we will get a good 10,000-foot view. Our first stop on the primary forms of delayed puberty is Turner syndrome. So this is where female patients have an abnormality in or absence of one of their 2 X chromosomes. Characteristics are short stature, a webbed neck, shield chest, and primary amenorrhea due to their streak ovaries, lack of follicles, and no estrogen production. Interestingly, though, 40% of patients with Turner syndrome are actually mosaics and can have variable degrees of functional tissue. In males, of course, we have Klinefelter syndrome, which is where they have XXY sex chromosomes, and this is characterized by a tall stature with a slightly feminized physique, mildly impaired IQ, usually about 15 points less than average. They will have small testes and can have gynecomastia in 30% of cases. I do think this picture is rather sweet because if you put them together, they have the right amounts of chromosomes. Would make a lovely rom-com. And to complete our tour of the primary causes of delayed puberty, we have gonadal agenesis. So this is where our complicated embryology comes into play when things go wrong, such as in Müllerian agenesis, which represents 15% of the cause of primary amenorrhea. And this is a spectrum, so there are varying degrees of Müllerian agenesis. I won't get into this here. And these patients can often have otherwise normal pubertal development. Remember, we define puberty in females as thelarchy. This may be more appropriately categorized as a disorder of sexual development, and this includes things like androgen insensitivity, XY gonadal dysgenesis, and Leydig cell hypoplasia, etc. Moving on to our secondary causes, we have idiopathic hypogonadotropic hypogonadism. This is where you have a defect in the production or the action of GnRH. There's a male preponderance here, and the causes are typically genetic, and they have identified many genes associated with this. Kallmann syndrome is also known as the anosmic form of idiopathic hypogonadotropic hypogonadism, and these patients have a defect in the production of cilia, which results in infertility and the inability to smell. For completeness, I have included short stature here. However, these patients may otherwise have normal pubertal development. But I do think it is important for us as family physicians to be able to address parental concerns, identify when there is a problem, and know the appropriate workup. So short stature is defined as more than 2 standard deviations below the mean for age, or less than the 2.3rd percentile. As part of your workup, you want to rule out secondary causes such as malnutrition, calculate the patient's height velocity, get a bone age or an x-ray of the left wrist, and calculate their mid-parental height. The most common causes are going to be familial short stature or constitutional delay of growth in puberty. So in calculating the height velocity, you look at how much a patient has grown and average that out over the year. If a patient has grown less than 2 inches per year, that is abnormal, and you want to rule out an endocrine disorder. If a patient is over 2 inches a year but have normal bone age, that's going to point you towards familial short stature. But if a patient has been growing more than 2 inches a year and shows delayed bone age on left wrist x-ray, then that's when you're looking at constitutional delay of growth in puberty. And these patients are potentially candidates for growth hormone therapy, which we will talk about later. As part of your workup for short stature, you will calculate a mid-parental height, and this can give you a rough estimate of a patient's anticipated height once they have completed growing. In female patients, you add together the mother and father's height in centimeters, subtracting 13, then divide by 2. In male patients, you again add the mother and father's height in centimeters, add 13, and then divide by 2. As you can see in this graph, the greatest height velocity you reach outside of infancy is during puberty. And finally, to conclude our secondary causes for delayed puberty, we have functional hypogonadotropic hypogonadism. This is where you're going to have chronic illness that throws off the HPG axis, such as celiac disease, Crohn's, Cushing's, diabetes, eating disorders, hyperprolactinemia, and thyroid disease. Moving on to our fifth circle, we have the initial evaluation. If you have a patient with a suspected disorder of puberty, then your history is paramount. You want to review all the pubertal milestones, looking at the onset and progression of body odor, acne, breast and testicular development, the appearance of pubic and axillary hair, any exposure to chemo, radiation, or exogenous steroids. Review the nutrition and exercise patterns of the patient, as well as their psychosocial functioning. And look for alarm symptoms such as anosmia, fatigue, abnormal bowel movements, pain, or neurological symptoms. It is also important to take an excellent family history, looking at pubertal milestones of the parents, such as peak height velocity, age of menarche, etc. Things like constitutional growth delay do tend to run in families. You will also want to calculate the height velocity of the patient using the growth chart, and perform Tanner staging, looking at the pubertal milestones on a scale of 1 to 5. If you aren't familiar with this, I encourage you to review this on your own so that you can properly diagnose which stage of puberty your patients are. Interestingly, the Tanner stage is named after James Tanner, who was actually almost an Olympic hurdler, but World War II happened. He then went to Hopkins and was a pioneer in the development of human growth hormone from cadavers. He's originally from England, so shout out to him. And if you don't have one already, consider getting an orchidometer this Christmas so you can appropriately Tanner stage your patients. Next, we have Circle 6, our diagnostic workup. For precocious puberty, your first step is to determine if it is central, peripheral, or a benign variant. You will do this by getting an FSH and an LH and observe to see if it is increased in the causes of central or gonadotropin-dependent precocious puberty. If it is decreased or normal, you're looking at peripheral precocious puberty. You can then move on to a testosterone estradiol to see if it is increased. Get an AM17 hydroxyprogesterone if CAH is suspected. And in the case of benign variants, this is all going to be variable, but you just observe every 3 to 6 months looking for progression of the pubertal milestones. In our workup for delayed puberty, a good first step is to get that height velocity. Remember, we're looking for less than 2 inches of growth on average per year. You can also get a bone age at this time, getting an x-ray of the left wrist. As part of your laboratory analysis, your first step is going to rule out chronic illness with the TSH, CBC, CMP, ESR, CRP, celiac screen, and iron stores. You can also consider getting a prolactin, as hyperprolactinemia can present initially as stalled puberty. You can look at getting an IGF-1. If this is normal, that can rule out growth hormone deficiency, but if it's low, it does not necessarily indicate that you do have growth hormone deficiency. Moving on, the most important part, perhaps, of your workup is going to be to get an FSH, LH, estradiol, or testosterone. You can also consider getting a DHEA at this time as well. If FSH and LH are elevated, then you're looking at a cause of primary hypogonadism, and you want to rule out things like Turner syndrome or Klinefelter via a karyotype, pelvic ultrasound, etc. If FSH, LH, and the hormones are low to normal, then you're looking at things such as constitutional delay of growth in puberty, an isolated GnRH deficiency, or functional hypogonadotropic hypogonadism. Continuing our workup for delayed puberty, in any patient with neurological symptoms, have a low threshold to obtain an MRI looking for pituitary or hypothalamic pathology. In boys where GnRH deficiency is suspected, a low inhibin B can be helpful in pointing you in that direction. There is a novel test known as the kisspeptin stimulation test, which can help differentiate between constitutional delay of growth in puberty and GnRH deficiency. Remember, kisspeptin is what we think starts the GnRH pulsation at the onset of puberty. But by God, at this point, I hope y'all have referred them to pediatric endocrinology. Moving on to Circle 7, we have treatment. For central precocious puberty, you are going to treat with GnRH analogs, and this includes leuprolide, histrelin implants, and triptorelin injections. In peripheral precocious puberty, your treatment is going to be based off the cause. For things like a gonadal or adrenal tumor, that will be managed surgically. For exogenous steroids, you remove the exposure. For CAH, you treat with glucocorticoids. In McCune-Albright, in females, you treat with lestrozole. And the benign variants, again, will be treated with monitoring every 3 to 6 months. In treating delayed puberty, the first step is to treat any underlying cause that you may have found in your workup, followed by hormone replacement therapy in girls older than 13 and boys older than 14 with possible constitutional delay of growth in puberty or gonadotropin-releasing hormone deficiency. They can be offered jumpstart therapy to induce puberty. And finally, monitoring. In patients with short stature that has been determined to be familial or idiopathic, who are less than 2.25 standard deviations below the mean and have an expected adult height less than 63 inches in males or less than 59 inches in females, they can be offered growth hormone therapy. This is going to ideally be given before the growth plates have closed, however. These are the indications for referral to pediatric endocrinology as per the AAFP. We have reached Circle 8, the conclusion. Puberty is a challenging time, and it's challenging to understand. Precocious puberty is defined as the development of secondary sexual characteristics before age 8 in females, 7 if African American, or age 9 in males. This is extremely variable. There are 3 types of precocious puberty: central, peripheral, and the benign variants. Delayed puberty is defined as no breast development by 12 to 13 in girls or no testicular enlargement in boys by age 13 to 14. Your history, physical exam, and pubertal milestones are vital. You first need to rule out secondary causes for any of these issues. FSH, LH, and hormones are a good start to an endocrine workup, but never be afraid to refer to pediatric endocrinology. This is Circle 9, my references. Thank you guys for joining me. Happy holidays.